Today, I hope to cover about the skin microbiome and its effects on AD, Staph aureus colonization in AD, itch in AD. This is another one of my pet topics. Oftentimes, we've got parents coming in telling us, I don't care about the rash, I don't care the way it looks, just get rid of the itch, doc. That's all I want. We often see this many, many times. So I want to talk more about it, okay? And then we'll be going through some case studies along the way as well. Okay, infections in eczema. I'm sure each and every one of us have either seen it, treated it, dealt with it, grumbled over it. It's very, very common. So this is impetigo, as you can see with the crusted yellow lesions. That's the giveaway on a background of eczema over the popliteal fossa. This is eczema hepaticum, as you can see from the crusted erosions over the V1 trigeminal nerve. The reason why I took this picture, particularly from DermNet, is because if you look at the tip of the nose, right there, is there a pointer here? Okay, don't know. Okay, never mind. So anyway, if you look at the tip of the nose, there is actually a crusted lesion there as well. So this is quite important when we are treating either zoster or eczema hepaticum or anything, because once the tip of the nose is involved in zoster, then we're worried whether is it the nasociliary branch of the V1 trigeminal nerve that is involved as well. So more than the dermatologist, you need to get the ophthalmologist in quickly here, just to make sure that the eyes, don't have any further involvement of the eczema hepaticum. Okay, and this is molluscum. Okay, so the big question is, why are skin infections more common in eczema compared with any other papillosquamous eruption that you can think of? There is psoriasis, we've all seen it. Psoriasis can be very extensive, yet we don't see infected psoriasis as much as we see infected eczema. Why is that so? So that's a key point to ask and to answer. So I hope to answer it today, okay? In order to answer it, I need to tell you more about the skin microbiome and its effects on eczema, which it does not have on the rest of the papillosquamous eruption. Okay, so what is the normal skin microbiome? Okay, so in any mucosal surface, there is millions of bacteria, fungi. We all know that. These are skin colonizers. They colonize the mucosa. And these are very important so that we don't get pathogenic organisms in the area. But particularly in the skin hosts the most diverse commensal microbial communities compared with any other mucosa. Let it be the nose, the throat, the gut. The skin is the one that hosts the most number of it. So this is a key point to understand. Okay? And not only does it host the most diverse number of bacteria, it also has got skin site specificity. So the bacteria that we see in the armpits, very different from the bacteria we see on the hands. And this is in each and every individual. Okay? So every site has got its own specific bacteria as well. And there's a difference in skin microbiomes in different stages of life. So let it be a baby up to an adult, the skin microbiome changes. In fact, actually from less than 2 months of age to more than 2 months of age, the skin microbiome is already different. So it's almost like your own personal thumbprint on your skin. The skin microbiome is very personalized for each and every individual. Okay? The skin microbiome is established in early life, in neonate and in infancy. So this is also very important because the pediatricians among us actually hold the key to reversing atopy, because that's when most of your skin microbiome is introduced. That's when you can actually get the skin to tolerate a lot of what we think are allergens, but at that age, there is actually, the skin is able to tolerate it instead of mounting a response to it. So the pediatricians are very, very important in atopy, okay? So and there's also crosstalk between skin and microbiome in healthy and atopic dermatitis conditions, okay? So we'll go through more about this. Okay, in early life, there is rapid immunological maturation in the neonatal period. So, neonatal immune responses demonstrate a reduced propensity for activation or inflammation compared with those in adults. We believe it could be because of the immature immune system, but more importantly, what neonates have are regulatory cells like toll-like receptors, okay, T-rex cells. These T-rex cells are super important because they tell the immune system, be quiet, this is a friend, not an enemy. So let's not get too excited when we meet this guy. So it's in the neonatal period that's when we are introduced to a lot of bacteria, and that's when our skin sort of learns tolerance to all of this as well. So if you remember the hygiene hypothesis that came about some time ago, so this is quite in keeping with that as well. So, we believe that there's more atopic conditions now, also because we are more aware of it, and also because we live in a more sterile and clean environment. Okay? So this promotes immune tolerance to self-antigens, foreign antigens, thereby preventing inflammation and disadvantages to the healthy tissue development. Okay? Okay, age-dependent immune crosstalk in skin. So let's see what happens when the same bacteria is introduced in very early infancy and in a later stage. Okay? So when you get Staphylococcus epidermidis introduced at a neonatal stage, so when you see Staphylococcus epidermidis being introduced at the neonatal stage, because of the T-Rex cells, it actually tolerates this commensal. Whereas when the same thing is introduced in an adult, you see a lot more inflammation. Th1, Th2 inflammation starts, and it causes more, inflammation at an adult stage with the same bug, actually. So the neonatal period is really, really important in introducing these bacteria and getting them to tolerate it as well. Okay, let's go through a case study. This is one of my patients. As you can see, it's a young child with very crusted lesions, particularly over the lower back and the popliteal fossa. This is, of course, it's a 2-year-old girl with a history of atopic dermatitis. She was on follow-up with a GP for that. She presents with this rash for 5 days. She's afebrile, but the rash is starting to spread to other areas, but she's systemically quite well. Okay, so what is this? It's quite straightforward. Okay, so this is impetigo. It's a very common contagious superficial skin infection that is spread usually by direct contact fomites. Staphylococcus is the usual cause of it, strep in a lesser percentage. It's most common on exposed areas, especially the face, hands, neck, and extremities. They may have fever and lymphadenopathy if it is very extensive, okay, but she did not have. All right, so this is impetigo. We've all seen this, treated it. The staph usually is present in the nose, the axilla, and the perineum. So this is why we usually do skin swabs from the nose to look for the staph if they are staph carriers. There are some predisposing factors. So having atopic dermatitis increases the carriage rate up to 90%. Sometimes you can also get it because of insect bites. That's usually the epidermis is sort of broken, and then the staph gets infected in that area. There can be presence of other infections which can also predispose to impetigo as well. Okay, so essentially, once there is anything that disrupts the skin barrier, okay, that's the key thing, and that's when you start to get staph infections. Okay, the treatment. So what do I do to treat it? If it is localized and the child is otherwise well, not systemically unwell, I just do antiseptic wash, compress to the areas, octenisan wash lotion, chlorhexidine, triclosan. Okay, this is the old slide. Now I should put in Ceradan emollient wash also there, okay, because it contains octenidine as well. Potassium permanganate just for the areas. I do it as a soak, normal saline as well. If it is extensive, I do give oral antibiotics, especially if it is spreading very fast, child is unwell. If it is recalcitrant or recurrent, or it is very extensive, I do skin swabs for bacterial culture sensitivity, just to figure out if it is staph, strep, what is exactly happening. I screen and treat for nasal carriage, and more importantly, I screen family members as well. So in children, nasal carriage, usually less common. In adults, a lot more common. So I make sure I treat not just I make sure I screen not just the parents, but more importantly, nowadays, the helpers, because they are the ones who are with the kids most of the time. So I make sure I screen them and I treat if necessary. Okay, so what did I do for this child? Okay, so I put in the aerobic swab and the nasal swab as well. I did the potassium permanganate compresses, antiseptic wash, topical potent corticosteroids, and oral cephalexin. Okay, this topical potent corticosteroids are a bit difficult, because here you are telling the parent, okay, so this is eczema, it is infected. Yes, we're going to do the antibiotics, but we're also going to give you steroids. Oftentimes they will ask you, doc, this is infection. Isn't steroid supposed to cause infections? What are you trying to do? Okay, so we'll go through this point a while later, all right? So this is important to address so they don't get scared of corticosteroids and further increase the phobia, the steroid phobia, okay? I treated her with oral cephalexin as well. Okay, so this is a child after that episode, actually after a few episodes. So she had recurrent AD flares every few months. So it was actually the eczema that flared up with the hot weather every time she traveled to a cold temperate country. But interestingly, she did not have any further infective flares of AD. So the infection was curbed. This is also important. You don't want to get repeated Staph aureus infections. That itself promotes more and more eczema. So most of her infections were actually, eczema flares are mostly in the flexure areas. You can still see she has got some of it left in the ankles and in the wrist as well. So treated her with betamethasone quarter strength, wet wraps with Ceradan advanced barrier and Ceradan emollient wash as well. So the emollient wash, I kind of like to just do it if they're starting up a flare. So that's when I find it very useful to sort of clear off any surface staph infections or surface staph from the skin, okay? Okay, next case. This was very recent, actually. So I just saw, I think, about a week ago or so. 3-year-old girl with a history of flexural AD presented with large flaccid blisters with confluence over the perineum, axilla, and perioral areas for 2 days. I was the second doctor she had visited. She has visited somebody else earlier who had given her some treatment, and then they were quite uncomfortable because it was spreading very fast. She has a mild fever, but she's running around in my clinic. Okay, so it's difficult to catch her to examine her kind. So she's quite well overall systemically. Okay. So as you can see, there is definitely some flaccid blisters. This one is a bit, okay, these photos are a little bit old because when she came, we were a little bit more worried and no one thought about taking photos. We just wanted to get her treated fast. Okay, so this was actually at subsequent visits. So you can see that it is a bit crusted up now, but this is where all her flaccid blisters were, all very fresh on an erythematous base. Bit of confluence is already seen over the area. This is her eczema areas. The perineum, she was very shy, so I didn't want to. And the face, obviously, I wasn't going to take for patient confidentiality. Okay, so what is this? So my thoughts were whether is this staphylococcal scalded skin syndrome. So that's the thing about private, right? Because you're literally an open door. You don't know who's going to walk in, what is going to walk in. So at least, in a restructured or, in an institution, there are a few doctors who would have seen before you, and they would have hopefully treated with something that you're like, wow, what is this? Right? So, yeah, so I was worried about SSS. And of course, because she was so well, it's been 2 days and she's not much of a fever, not quite unwell, still running around. But the thing with children now, they have a little bit of a reservoir, reserves. So they will run around until they deplete it and then they'll collapse. So it's also it's difficult. The pediatricians will understand. So you can't just depend on the fact that, okay, the child is well and therefore it's okay. So I did what I do. So I offered admission and the parents, they couldn't cope. So one parent had to stay in the hospital, right? The child is admitted and there was no way the mom would cope. So she said, it's okay, I'll take care at home. I gave her my number. If there's any issues, she'll come to the A&E in the middle of the night. We'll admit and we'll do what is necessary. And she already had 2 other kids with her at that time. So bloods was also a bit of an issue. So we thought, okay, never mind. Let's just treat and then we'll see how it goes. I got the aerobic swab done. I started treatment with oral clox and clindamycin, which is what we do for staph, scalded skin anyway. And I gave potent topical steroids. Mom at this moment was like, anything, la doc, anything, just do whatever you want. It's fine. I'll just, as long as you don't ask me to get admitted right now, we can manage it. So, and then we started off with the antiseptic wash. We gave the skin barrier cream. So I love the skin barrier cream as well because it's very thick. It gives me a very, very nice thick consistency. So I was really worried whether her flexures will start peeling up. All the flaccid bullae it will deroof itself and there'll be erosions and whether they will get infected. So I did the Mepilex dressing for that as well. Then I checked the nasal carriage for everybody at a later visit. And she also has got a 15-month-old younger sibling. So the thing with bullous impetigo is that it spreads. It spreads by direct contact. And these 2 girls love to play with each other. So yeah, indeed, the younger one did have impetigo lesion on the neck. She had a single one as well. She was also otherwise quite well. And okay, so fast forward a few days. I think I saw her about 1 or 2 days later. She responded well to treatment. There were no new lesions and it started healing up very nicely. So this is probably bullous impetigo, okay? So there was no further progression. Then we switched to the wash after 1 week and she's fine, all right? Okay, so staphylococcal scalded skin syndrome, what is it? Superficial blistering skin disorder that's caused by exfoliative toxins. So just because you take a swab from that area in real staphylococcal scalded skin syndrome, you may not even get the staph because it is toxin mediated. Okay, it's desmoglein 1 mediated disease. So therefore, you may not even isolate the bug itself. Who gets it? Mostly the neonates. So the neonates, no chance lah, I would have admitted. Even there's a small little worry about it, or I would just admit straight away and call the pediatricians. Okay, very important, all right, because they need to manage the rest of the systems for us, right? And less than 5 years of age. Why does it happen in this age group? We're not entirely sure. We believe it's probably because of lack of protective antibodies to the toxins, immature renal function with decreased renal clearance, as well as an increased amount of desmoglein 1 in the skin at a young age. Sometimes chronic illness, especially renal disease, can also predispose. Overwhelming staphylococcal infection and immune deficiency, all these are reasons why children can get it as well. Okay, so that ended well, but it's a very important condition to know. Okay, it's one of the dermatological emergencies, one of the few dermatological emergencies, and you just never know who's going to walk into the clinic. So it presents as abrupt, widespread, tender erythroderma and tissue paper-like wrinkling of the skin, which is mostly accentuated over the flexures and the perioral areas. So that was classical in this girl. She had it over her perineum, over the perioral area, as well as the armpits. Mucosal membranes are characteristically spared. So within 24 to 48 hours, we'll start to get fluid-filled blisters develop within the erythematous areas. The blisters enlarge, form bullae, which are thin-walled, flaccid, and rupture easily. Okay? And the affected skin may then start to desquamate due to the illness, due to the loss of the roof of the bullae, leaving a moist erythematous area, giving rise to that scalded, that burnt skin appearance, hence the name of this. Okay, so there you go. Okay, that's right. You have the flexural accentuation and around the mouth, perioral crusting. So it's important to realize that in darker skin, the erythroderma is not very obvious. Okay, you can't just say this is not it because you don't see the erythroderma. So in fact, this was a child that we saw in KK with actually flexural accentuation. You see the perineum, it's all desquamating. So this is the later stages of staphylococcal scalded skin, okay? And as well as the armpits, you don't see much erythroderma, redness of the skin, simply because it's an Indian child, okay? That's why you don't see it, all right? So you've got to understand that as well, all right? So, but one thing that will be key is actually tenderness. When you rub your fingers over it, they will start to feel a bit ouch. They'll be uncomfortable. They wouldn't let you do it. Okay? What do I do to treat? Supportive treatment is key to handling these patients. I don't think I even know how to order an IV drip for a child. It's probably calling the pediatricians very soon for any of these cases. Okay? And analgesia is important. Isolate the patients. Minimal handling because the skin is very fragile. Treat them like burns patients essentially. And of course, the skincare dressings, so non-adhesive dressings are very important because you don't want to cause further skin damage. Treat them with penicillinase-resistant penicillin such as cloxacillin. Clindamycin gives an anti-toxin effect as well. That's why we add that on also. And in recalcitrant recurrent patients, actually, I wouldn't even wait for recalcitrant recurrent. This kind, I would immediately swab everybody's nose, treat whoever I can, and because I would never want to see this and another case of this. So you don't need to wait until it is recurrent. This is something that I would just pounce on everyone and just do whatever I can in order to make sure that it doesn't repeat itself. Okay, complications, it's toxin mediated, so therefore it can have systemic complications. Early recognition, supportive treatment is essential. All right, so Staphylococcus and NAD, so there is a well-known association between the two. There is high prevalence of Staph aureus colonization and secondary infections in AD patients. It's a very complex host-pathogen relationship, okay? And the host factors so include hostile environment that is created by the AD, and that leads to a microbiome dysbiosis, and that causes more and more staph to be colonized, all right? In essence, that's exactly what happens. But of course, let's go through it a bit more. So what does Staph aureus do? So this is a Staph aureus right there for you with all its surface proteins. So it's it has got a lot of these surface proteins that can adhere and colonize the stratum corneum. Okay, that's the key feature of Staph aureus. And that causes epidermal dissolution. So there's epidermal skin barrier dysfunction because of the staph as well. Okay? And that leads to immune evasion by inactivating AMPs, and that causes a pro-inflammatory mechanism which directly drives your Th2, Th17 innate immunity in the skin, promoting or exacerbating the inflammatory component of AD. Okay, so AD patients have got a higher Staph aureus colonization. I think we all know this. And they're more likely to be colonized by Staph aureus as well. So lesional skin has got 20 times more likely to have Staph aureus colonization in AD patients compared to healthy controls. Non-lesional skin as well. That's why a wash is very important, because you don't want to just apply the antibiotic creams just to the infected areas, but you want to just get a wash all throughout the skin, because non-lesional skin is 8 times more likely in AD patients to have colonization with Staph aureus compared to healthy controls. Okay, so what's so bad about staph? Why do we hate it so much in AD? Okay, so what are the implications of this colonization? So the implications are that, number one, the colonizations can reach up to 10 million colony-forming units, okay, in AD patients without clinical signs of infection. So this has got important implications for both the patient and the environment. The environment being the family members, being the rest of, their workplace, the home environment. Okay, so what is the implication? So for patients, important cofactor for increased rates of persistent and risk factor for development of purulent skin or systemic infections. Okay, this we can understand. For the environment, it's basically a source of potentially pathogenic microorganisms for transmission to contacts. So like my patient who had a younger sibling. Some patients may have younger siblings who are still in their neonatal age. So it increases the risk in these patients. And colonizing Staph aureus tend to spread from eczematous skin regions all over the body surface as well. Okay, so within the same patient, it can spread as well. Okay, so early life colonization is linked to subsequent AD development. There is positive test results for Staph aureus at least once during the follow-up was associated with increased AD risk. And the hazard rate of AD is 5 times higher when they are tested with Staph aureus. Okay, so in a healthy skin, you can see that there is a multitude of different organisms there, and there is skin microbiome diversity, so things are going on pretty smoothly. Whereas in atopic dermatitis, in a non-flare condition, you can already see there is definitely more Staph aureus down there, as represented by these red little circles. Whereas during a flare, it increases, in a tremendous fashion as well. And that also causes a lot more of inflammation. Okay? So the bacterial communities also shift during AD disease progression. So with every flare, you get a different host of bacterial communities on the AD skin. These are all pathogenic bacterial communities, and then you have to end up treating more and more and more of it, okay, with every AD infective flare. So a significant inverse correlation between objective SCORAD and this diversity during the flares. So this leads to reduced skin bacterial diversity, which then corresponds to worse AD severity. AD flares and severity is specifically linked to Staph aureus abundance, and only Staph species specifically, the relative abundance of Staph aureus was significantly increased during the flares. So Staph is something that we have to respect and to be able to treat properly and appropriately, not just during flares. I'm not just talking about the oral antibiotics, but even post-flares as well, in order to prevent it from coming back out again. So this brings us to the next question. So if we, in some manner or other, if we can replace the skin microbiome, give it back the diversity that it deserves, then can we potentially treat AD? So coagulase negative staph could be therapeutically beneficial in AD. There are birth control studies that have shown presence of staph other than Staph aureus at 2 months of age, and this can actually protect infants against later development of AD. Okay, this was in rats, not in humans. So, but coagulase negative staph have anti-Staph aureus functions as well. So that really is quite useful. But however, how do we do it? What are the different types of coagulase negative staph? So we don't completely understand it. We don't have that magic cream, that magic skin probiotic yet that has truly shown to be useful. So until Hyphens comes up with it, I guess we have to just make do with what we have right now. So the effects of antiseptic bath and topical corticosteroids on skin microbiome. Okay, so this is important to understand. Remember I said parents will question you. Doc, you told me it's an infection. Now you're giving me topical steroids. I read steroids can cause further infections. What are you trying to do? Right? So it's important, even if they don't ask that, they'll go home and then they'll think about it. And then they'll stop your topical corticosteroids. So we have to explain to them that actually there have been studies done looking at the skin microbiome using these topical corticosteroids. So what happens when we actually put on the topical corticosteroid on an AD patient and then we test the skin microbiome before and after? Okay, so at baseline, the densities of Staph, including Staph aureus, were higher in lesional AD compared with non-lesional AD and control. So this we already know from before, right? And bacterial communities significantly differed from each other in lesional versus non-lesional. So not only was there higher Staph, but overall the communities were also quite different. So after we put on either the topical corticosteroids or the bleach bath, which is the antiseptic wash, and the topical corticosteroids, the bacterial composition and the Staph aureus density started to normalize both on lesional and non-lesional skin. So it starts to get more towards normal. So it's important to make them understand it. So just reducing the inflammation that is caused by all of this staph does help to reverse the skin microbiome more to what it's meant to be. Okay, so it's important to understand and explain this to them so they don't get too scared of the topical corticosteroids. Okay, Staph aureus recolonization. It's a very persistent problem. So I was very, very happy with my first patient who had impetigo, and I managed to, it's been over a year since I followed her up from the previous clinic to now. So, and she's managed to actually stay out of infective flares. So I always pat myself on the back for that. So at least, she still has got AD flares, don't get me wrong, but it doesn't become infective flares, okay? So this is a very, very persistent problem. And so out of 60% of the patients were recolonized 4 weeks post-treatment. So it comes back very fast, and 100% of the patients were recolonized 8 weeks post-treatment, okay, with Staph aureus. There are potential factors, nasal carriage, we've gone through that, presence of close contacts were also Staph aureus carriers, we've gone through that as well. So a more proactive control of Staph aureus in patients would be required to control disease progression and thus improve chances of remission. Okay, so this is important. So it's not just what you do during the flares, but what's more important is what you do after that so as to prevent the next infective flare from coming up. Okay, so microbial interaction can affect the atopic march. If you don't treat the skin properly, it can have a crosstalk with the rest of the mucosa, particularly the gut, the throat, the nose, the airways, and that is basically your basis for the atopic march. We all know that atopic march starts with the skin, okay? It starts with the skin, it starts with eczema, and then it goes on to develop food allergies, asthma, allergic rhinitis, and other conditions as well, okay? So it's important to respect the skin microbiome. It is the most diverse, it is the largest organ, and just treating that properly does help to prevent the atopic march from progressing also, okay? So current therapies with effect to reduce the Staph aureus colonization. So what do we have? Antibiotics. Well, we know even topical antibiotics can increase the risk of resistance and sensitization. The topicals there's a compliance issue with it, and systemics. I use it when it's very extensive. Otherwise, I tend to just sort of stay away from it if I can. Okay. Bacteriotherapy, topical probiotics. We don't know. There's conflicting data. No magic cream yet. Topical microorganisms, we don't know about the long-term efficacy and the safety data. The topical antiseptics, so there is a recommendation by ETFAD in addition to anti-inflammatories, if clinical signs of strong colonization or bacterial superinfection is present, this is preferred over antibiotics due to the risk of less bacterial resistance, okay? Emollients, this is central pillar to AD management. I'm sure we all do this as well. So it's important to also rebuild the skin pH also. Okay? So what Ceradan has basically done is that they've incorporated the antiseptics into the regimen, and this is more beneficial than just emollients alone. So that's basically the basis for their current Ceradan emollient wash. Okay, so the next patient, this is a 16-year-old boy with severe chronic atopic dermatitis. This is the itch story that I usually like to tell. Parents have stopped all steroid topicals after reading about topical steroid withdrawal. Patient is unable to sleep at night. There's poor performance in school. Remember, he's 16 years old. Mom is not interested in all your treatments. She doesn't want to hear. She just wants you to stop the itch so the child can sleep at night and sit for the O-level exam. Okay, so the O-level exam is more important than the skin and more important than the child. Yes, we often see this, we often face this. How do we deal with it? So, treatment for itch in AD. Okay, the intense pruritus is major and burdensome symptom of AD. Traditionally, management of itch in AD patients has focused on restoring the skin barrier with topical emollients, reducing the inflammation. However, most of the conventional treatments, they fall short in treating the itch properly and appropriately. Okay, this is something that I do see in the clinic. Yes, doc, the eczema is better, but he's still scratching at night. I can still hear the at night. You know, if you talk to parents often enough, they will gladly tell you all this. In fact, if you don't want to hear also, they will want to tell you about all this, right? So there is a growing emphasis that's been placed on directly targeting the neural transmission pathways that mediate itch signaling. So this is important, especially for the severe AD patients, where it's not just during an AD flare that they scratch. Even without the AD flare, so, you know, the pathways have gotten, you know, they are irregardless of the AD pathways. So the itch has got its own mind and it's got its own driving force. If you have seen enough severe AD patients, they'll tell you, when the fan is blowing, I'll start to feel itchy. So it's that bad. You know, you don't even need an actual trigger, like wind blowing across. They can't wear very heavy clothes. The material has to be super soft. If not, they'll start scratching all over. Okay? So this is more so for the severe AD patients. So it's important to understand that it's not just the immunomodulatory axis, there is also a neuronal axis in the itch pathways. Okay, so this is very important. Itch management requires clinical phenotyping into the reason for etiological subtypes with varying degrees of inflammatory, systemic, neurological, and psychological dysfunction. Recalcitrant itch often requires a combination therapy using both topical and systemic agents, and it should be affecting most of some of these pathways at least, not just the immunomodulatory pathways. Okay, you have to consider the neuronal pathways also. Okay, so how do we treat the conventional itch in AD? What do we do? Okay, so first we do our emollients, TCS, TCI, we give the antihistamines, and then after that we do the narrowband, the cyclo, MTX, the AZA, the MMFs, and if that doesn't work, or if it's a young child and the parents don't want the side effects, then we go on to our IL-4, 13s, and our JAK inhibitors. This is how we basically treat AD and the itch right now. Okay, but this alone is not sufficient. Okay, that's basically my point. Okay, so there are different targets for treatment of itch. So remember the neuronal axis, okay? So it's important to also think about the topical menthols. We have this right now. The topical anesthetics, I haven't tried it. There has been some papers on it using lignocaine, capsaicin, but I haven't quite tried it. It's not very easily available in Singapore, and I'm often worried about causing irritation as well. So the gabapentin, the pregabalins, those are important as well. The TCAs, I do use this in very severe eczema patients. I have found it to be quite helpful. Okay, so the neuronal axis, once again, the treatments for chronic itch where they work in the central or the peripheral nervous system. All right, so all these are the different ones. So these are the systemic therapies. Basically, I'm trying to highlight mirtazapine down there. All right, and as well as the SSRIs also. So basically, mirtazapine is a serotonin and a norepinephrine antidepressant. It has been reported to reduce pruritus in AD as well as in other chronic pruritic dermatosis. It also exerts anxiolytic antihistaminic effects also. I have found it to be quite useful even in young children. When the eczema is that bad, you just need to do something. So that's usually when I tend to use it. All right. Only thing you need to understand is that there is an interaction with cyclosporin. So if you're planning to start cyclosporin, then I probably should call in the psychiatrist to start on something else. Okay, so these are the different steps. Once again, it's mal-aligned. But anyway, it's the same thing all over again, all right? So do consider the gabapentins in older patients or the antidepressants. Okay, so let's go on to the next case. 10-year-old Hispanic boy with a known case of mild atopic dermatitis presents with this acute extensive rash for 2 weeks after returning from a beach holiday. This I saw during my HMDP in Boston Children's. So that's why it's a Hispanic child, very nice child who had seen multiple doctors, was being investigated for rheumatological conditions, connective tissue disease. They were thinking he's got dermatomyositis basically, but it's an acute rash. No doubt it's after a beach holiday, so there is some sun involved, but it is an acute rash and he's systemically otherwise well. So if I were to just describe the rash to you, I'll probably call it multiple scattered, some confluent purpuric papules over the dorsum of the hands. Basically over the dorsum of the hands, at least in these pictures. He also had it over his feet and as well as the buttocks. Any ideas? Yeah, so this was eczema coxsackium, hand, foot, mouth disease. All right, so it was quite unfortunate. He went on to have like a skin biopsy. He already had his bloods done, and he was already seeing a rheumatologist. And the mom just wasn't convinced. And then she came to Boston Children's for I think a third opinion. And indeed, it was actually eczema coxsackium. They came pretty early on. So they were in the same hospital. I think they were seeing like three different specialists. So we managed to catch it early on, and indeed the PCR was actually positive as well. And it just so happened that 2 days after seeing us, they sent us an email to say that, oh, the cousin who also was with him during the beach holiday also has got similar lesions as well. So that sort of, became even more clear. So it is easy to miss this. When we see it alone by itself, usually it gets picked up, but in the presence of eczema, it can look quite extensive and it can cause quite a lot of worry. And it often has got that purpuric look, which often goes for vasculitis, right? So which is why we often tend to be very worried and then investigate more rather than less, okay? But this is important to keep at the back of the mind, all right? So eczema coxsackium, it has been seen before. Children aged less than 5 years are most often affected with transmission occurring via fecal-oral route. A16 and enterovirus 71 are the two most commonly reported, but CVA6-associated hand-foot-mouth disease can often cause a more extensive and the atypical exanthem. So this guy actually turned out to be a CVA6, all right? So it wasn't EV71, sorry. So these are the different sort of manifestations that we see. So it can be bullous as well. Okay, so next case. So the next few cases are actually not AD. So in giving an atopic dermatitis talk, I often try to balance it up and say that although as prevalent as it is, as common as it is, do think about other conditions as well that can mimic AD, particularly in the pediatric population. It's quite easy to not think about it. Maybe in the first 1 or 2 visits, sure. But the third visit or so, do consider these others. So I often put in a few of these so as to balance out the talk. So you always got to remember at the back of the mind, it's not all AD lah. All right. So this is an 8-month-old infant was admitted for extensive AD and diarrhea. Growth is faltering and she has failure to thrive. Of course, it was attributed to the extensive AD that she has. All right. So she was treated with multiple potent topical steroids, but has not improved. Thankfully, mom is not topical steroid withdrawal yet. Okay, she's not phobic yet. So the bloods showed peripheral eosinophilia, hypoalbuminemia, raised IgE. I must say, I wasn't the smart one who did all these bloods. Okay? It was the pediatricians in KK who did all the multitude of tests. And indeed, they found that she has got, so this is basically her. You can see it's very, very extensive. It's all over the limbs. This is actually eosinophilic esophagitis. And this is her, sorry, I think all the all the photos are all very mixed up. Okay, so this is not the patient here, okay? So this is the patient. This is her after her treatment, actually. So you can see it actually cleared up very nicely, all right? And actually all the abdomen and the legs all cleared up. So just with the elimination diet, just with making sure what was she allergic to, they just eliminated that. She had her scopes done, and she did very, very well, actually. Okay, so eosinophilic esophagitis, it's chronic immune and antigen-mediated disease that is characterized by eosinophil predominant inflammation in the esophagus. The dominant antigens that mediate these disease are food antigens. So it's very important to get the allergist in, to get the gastroenterologist, and they've got a multi-D in KK, whereby they sit together and they actually eliminate the right food. So the symptoms are usually feeding problems, vomiting, abdominal pain in children, dysphagia, food impaction in adults. So most of the patients affected by EOE have other atopic diseases such as allergic rhinitis, asthma, IgE-mediated food allergies, and atopic dermatitis. So indeed, the rash that we saw is atopic dermatitis, but the treatment is not just the usual topical steroids. And, we have to consider other diseases as well. So until the underlying food allergies were eliminated, this was not going to get better. Okay, so management is multidisciplinary approach. Okay, next case, 6-month-old infant. Okay, so this is the infant, all right? As you can see here, presents with scalp, groin, truncal rash for 3 months. He's been treated for seborrheic dermatitis, no improvement at all, all right? So once again, if I were to describe the rash for you, this is not the rash. Basically, it's multiple purpuric papules, petechiae over the trunk, the groin, some on the scalp, okay? So that is basically what I would describe it as, not an itchy condition at all. So this was actually Langerhans cell histiocytosis, right? So the purpuric papules and petechiae, those were the giveaway actually for this condition. It's a disorder that is characterized by infiltration of multiple organs with Langerhans cells. This, of course, was then taken over management by the heme oncologist and was started on the appropriate chemotherapy for this. So remember, in Langerhans cell histiocytosis, they can present with a seborrheic dermatitis-like eruption. Okay, so particularly over the septum areas, the cradle cap areas, the perineum, the upper chest, that's usually where it can appear as well. All right, so if you have a recalcitrant septum that never seems to go away, or maybe gets a bit better but never clears off, then definitely consider a biopsy. Okay, next case, 4-month-old neonate presents with an extensive red scaly rash for 3 months, failure to thrive, has already had multiple infections requiring prolonged antibiotics just in that short span of life. Okay, once again, my photo is gone. Okay, so anyway, take it from me, it's actually Netherton syndrome, all right? It can look very much like AD, can look very much like extensive AD, all right? But the giveaway is once again all the infections that they've had, the failure to thrive, and the rash does not improve with topical corticosteroids as well. Okay, so that also helps. There's a genodermatosis. It includes ichthyosis, atopy. So they do have multiple allergies. It is part of the genodermatosis. It is autosomal recessive condition, presents with it during the neonatal period with generalized scaling, erythroderma, and failure to thrive. Okay. Okay, so when is a red scaly rash not eczema? Okay, so this is my sort of take-home message. If the child is not so bothered by it, if it is acute, a generalized rash at onset, if they don't have a classical distribution or the appearance, and they don't respond to any of your good treatments, then it is something you have to consider something else. If there is associated symptoms like diarrhea, weight loss, poor weight gain, also do consider some other diseases. Multiple infections at an early age is also definitely an alarming bell. All right, so in summary, skin microbiome plays a key role in treatment and in prevention of eczema flares. So know it, respect it. Don't give the antibiotics too freely, but at the same time, you have to manage further infective flares as well. Staph aureus management is of utmost importance in treating the eczema. All right, with that, I come to an end. And so that's it. I've left my email address there if you've got any further questions.